Okay. All right. Well, my name is Andrea Sobrato, and I'm with CFPIC, and I have the pleasure of welcoming everyone this morning to this training provided by CFPIC and CWDA. I'd like to recognize Baljit Hundal, who is with us today, a former agency leader and a CalAIM rock star. CWDA has been a wonderful sponsor and supporter of this work on behalf of their member counties, and we at CFPIC are especially appreciative of the opportunity to partner with CWDA to help us carry out our charge to support human services leaders as they address the emerging needs and opportunities of their communities. I hope you find value in today's training, as well as the opportunities for technical assistance that follow. Before I introduce our trainer, Gretchen Schroeder, I'd like to set the stage just a little bit. If you could drop your name and county into the chat, that would be great. Today's training is CalAIM 201. And how many of you attended 101? Okay, well, as most of you know, the goal of that training was to provide an in-depth overview of CalAIM and set the stage for some more learning about Medi-Cal Managed Care's role in implementing CalAIM strategies and what those opportunities for county programs were. Today's training will build off the 101 training by focusing in on those leverage points for adults and children's programs, particularly around enhanced care management and strengthening community supports for families, individuals, youth, and children. Most of you have already met our trainer, but for those of you who haven't, Gretchen Schroeder is a community health strategist and has extensive experience working with Medi-Cal and CalAIM implementation across a variety of contexts in California, from public health to CBOs to public social service agencies. She has both the history and experience working with Medi-Cal over the years, including payment models, negotiating contracts, understanding the ins and outs of claiming, but she has been around implementation of enhanced care management all over the state, so can answer just about any question that you have. You're going to love hearing from her today, and we hope that you will take her up on her offer to provide more direct experience and support to you during her office hours. You're going to hear more about that from her, what we're offering, these TA sessions or office hours. You're going to hear more about that at the end. But we have a small enough group today, so we're not going to turn this into a webinar, and that just means this is super informal, and it's hopefully comfortable enough for you to drop questions into the chat, raise your hand. I've watched Gretchen train over 8 times now, and literally just throw your hand up and she will stop and work your question in a way that actually enhances the content in that moment. So please don't be shy. It actually enhances the quality of the training if we're throwing our questions and our thoughts and reflections in as she goes along. So I'll trust y'all to do that. And like I said earlier, Baljit is here to wonderfully complement Gretchen with insight from the county services side and to bridge any gaps in terms of application. So Baljit will be also fielding a lot of the questions in chat and also may chime in from time to time. We'll meet until about noon today, and we're going to have a stretch break at midpoint. I am recording, as you know, and I will send a copy of this video out to all of you in a few days, and maybe even after the series wraps on June 24th, just to make sure we get the very best version of the training. I'll also drop the PowerPoint slides into the chat in just a moment. And at this time, please join me in welcoming our trainer and facilitator, Gretchen Schroeder.
Good morning, Andrea. Thank you for that great introduction. It's good to see a few of you again. I recognize some faces and names, so thank you for coming back to the 201 training. Yeah, as Andrea said, please raise your hand, put your questions in the chat. I'd love this to be a conversation more than just a training. So look forward to that. And Diana, I saw you come on screen earlier and you have this beautiful backdrop. So I'm just going to pretend I'm in an orchard alongside you in Lake County. So yeah, if you feel free to come on camera, be great to see your faces. Right now, I'm going to share my screen and we will jump into our training. And so one of the things that we're going to be talking about today is really the ECM and community supports aspect, along with transitional care services. As you know, things are evolving with the budget, so it's always going to be interesting to see where we go. But right now, ECM and community supports are not being impacted by the current budget woes. So that is the good news for this year. As Andrea mentioned, we've been having many of these trainings, and I actually realized there's an error on the slide. We do not have one tomorrow, so I'm going to move forward with this. Our training objectives today are going to be doing an overview of ECM, community supports, and transitional care services. We want to help build an understanding around ECM and community supports capacity, and I'm going to talk a lot about what a county's role potentially could be in these programs. And then we're going to look at how do we leverage the points for CWS and adult programs within ECM, community supports, and transitional care services. So lots to cover today. As always, we have a really packed agenda, but please jump in with questions at any point in time. We're going to start off with a quick poll just to see what is your experience with ECM and community supports. Are you an expert? And there may be a few of you in here today that are experts. A few of you may be dipping your toes in, but still learning. And then a lot of you may be just novice or curious. We call it CalAIM curious is kind of the phrase that we use a lot. And then a few of you may have no idea about either, and you're here to learn more. I know we have some experts here. I see your names there, so I'm hoping someone's going to admit to being that expert. All right, looks like that we have come to almost, the polls have stopped. So it looks like most of you are novice curious, CalAIM curious, here to learn more, dipping your toes in. So I look forward to having you share your experiences, what your thoughts are, how your county is thinking about doing ECM and community support, so we can talk more about that. But right now we are going to jump into a quick Medi-Cal overview. If you came to our 101 training, you heard some of this before, but I do want to make sure that we're all on the same page and starting on what is Medi-Cal and why is it important for ECM and community support. So for those of you who are not familiar, Medi-Cal is California's Medicaid program. We have to rename everything in California. And it's a public health insurance program that provides needed healthcare services for qualifying individuals. And qualifying individuals means folks that are of low income, who may have disabilities, foster care, pregnant women, and then certain diseases can qualify folks for Medi-Cal. Generally speaking, Medi-Cal is shared 50-50 with the federal government, so they pay 50% of the costs and California pays 50%. There are some exceptions with certain programs or populations where that share is different, but generally speaking, we think of it as being a 50-50 share. What I do want to spend a moment on is Medi-Cal enrollment. And generally, we hover around 15 million people in California that are enrolled in Medi-Cal. And what's going to be key for the programs we talk about today is roughly 90 to 95% of folks who are in Medi-Cal are in managed care. So when we think about all of the changes the state is rolling out in Medi-Cal, this transformation we're undergoing, and they're pushing it all through the managed care plans, this is why most of our folks are in managed care. So if we want to reach everybody, or most everybody, we're going to do it through managed care. Medi-Cal benefits are going to be important, and this benefit word is going to be something I'm going to emphasize over and over again. We do have a comprehensive set of health benefits that folks qualify for in Medi-Cal. We also have this category the state calls other, and this is where you're going to find enhanced care management. This is a benefit of Medi-Cal. We also have our transportation services, community health worker services. Those are all benefits. What you are not seeing here is community supports. That is not a benefit under Medi-Cal. It is an optional program for the managed care plans to offer. So as we talk about these programs, there are different incentives for managed care plans to offer community supports, for example, versus the benefits they're required to offer through their contract. Any questions on that? All right, we will go to why are we transforming Medi-Cal? Why is the state making this big push? I mean, I think there are many reasons. We can talk about the benefits to all of our citizens, to having better healthcare, but I think what's driving this a lot is going to be cost. And so when we look at why we're doing this, we know that Medi-Cal members typically have several complex health conditions. And that involves several different providers. And so when I look at different places, and actually the former director had this great map of people that have complex health conditions and how many different providers they have to engage in delivery systems and how complex it is. What Medi-Cal and the state are trying to do is really streamline that. So how can we break down silos, have someone help individuals coordinate the care for their complex health conditions and streamline that process? So that's one reason. We also know that we have a lot of different delivery systems, and we want to make sure that we're not duplicating efforts, duplicating services. So again, how do we coordinate that care? How do we engage folks in a meaningful way without having them run all over the state to get the services they need? And then the last piece, which I think is really important and will inform some of the reasons why we're doing ECM and how we're trying to target different populations, is that we know that more than half of Medi-Cal spending is attributed to the 5% of members with the highest cost needs. So we are trying a lot of these programs to target that 5% of the Medi-Cal population, trying to capture them, coordinate their care, and reduce those costs, improve their outcomes, et cetera, et cetera. So this will drive a lot of the conversations we have, especially around ECM. So the state has a great program they've called CalAIM. They are trying to rebrand this as Medi-Cal Transformation. I'm going to use both terms interchangeably. They've tried to rebrand CalAIM a few times before, and it's never been successful. So we'll see how this one goes. But CalAIM is really a multi-year effort to change the healthcare delivery systems within California's Medi-Cal program. So it's trying to, again, build this coordinated, person-centered, and underscore this, equitable health system. So we're trying to really bring together services that can address physical and mental health and social determinants of health needs. We want to integrate care, and we want to really be a catalyst for equity and justice. So these are the themes that you'll see throughout these programs that we'll revisit over and over. So why does all of this matter? And why should we as counties care about these transformations? How does this impact our lives and the folks that we work with? So a couple things here, and if you're an expert in Medi-Cal or CalAIM, jump in here with your thoughts around this as well. But we do have these new benefits and services that are available to vulnerable populations. I think those are good things. We have new revenue streams coming into the counties for providers and potentially for counties to support these types of services. And a lot of these services are already taking place in our communities. They're just not being reimbursed. So this is a way to get more dollars to get reimbursed for the work that's already being done. And then I think most importantly, and we're starting to see this happen more and more, 2.5 years into CalAIM, we're seeing some silos being broken down. We see folks talking to each other, trying to coordinate care in a meaningful way. And that's been really exciting. I work in a lot of different counties across the state, and seeing this starting to happen has been very rewarding. All right, you guys are Medi-Cal experts now? I'll see someone nod their head. Maybe Belgique can nod her head, and then we can move on. All right, great. Now we'll go into the history of Medi-Cal transformation. How did this start? How did we choose this type of program to really launch? And so really, and a few of you guys are familiar with these programs, the state launched the whole person care pilots back in 2016. And those were a little bit different than CalAIM because those were driven by the counties and the city of Sacramento. We had one city that did it. And they're really trying to test, do these interventions work? If we try to break down silos, coordinate care, address both physical health, mental health, and social determinants of health, do we see better outcomes? Do we save money? So we did that. Results were really promising. Yay, whole person care was a success overall. The state also launched the Health Homes program, which was trying to drive some of these changes through the managed care plans. And that was run by 17 managed care plans in 12 different counties. And I think that had mixed results, but it certainly informed managed care plans of what this was going to take and where they needed to invest more. So I think overall, both programs were a success. They did have really significant outcomes for improving health outcomes and saving money. So all of these things led up to the CalAIM programs for ECM and community supports. So the state's vision for CalAIM was to really take the learnings and the designs that were tested across California through whole person care and the Health Homes program. We wanted to move beyond county pilots to really standardize statewide implementation. So we're trying to have this be standardized across all counties, across all managed care plans, to really create this more community-based care system, coordination of physical health, mental health, and social services. And again, most importantly, is trying to integrate the work into the managed care delivery system, get that payment system set up so we can get reimbursed for the services that we are providing that are often Medi-Cal benefits. And then one thing that you're going to see, especially in some of the new populations of focus that have come on board for ECM, is we want to keep folks in the community-based setting when it's appropriate for them and they want to be in the community instead of going into a skilled nursing facility or into other institutions. So really trying to keep folks in the community, in their homes when appropriate. So we'll see that theme again throughout all of our programs we'll cover today. So I warned you we're going to talk about this a lot, but I really want to engage counties as to what is your role in these programs. And so we're going to revisit this throughout ECM and community supports. But I think there are three big buckets I see for counties across the state. One is to become a contracted provider with the Medi-Cal managed care plans for either ECM or community supports. That may not be for every county or every county agency, but that is one option. The other role that I think is really important for counties to consider is becoming a referral partner. So you guys engage with a lot of vulnerable populations who may qualify and benefit from ECM and community supports. So how can you incorporate that into your programs, into your intake processes, into how you do business? So thinking about that. And then the third option, I think, is being that capacity builder for your community. How do we let folks know about these programs? How to make referrals? That could be providing meeting space for providers to come in and gather and do some work together to break down silos, really coordinate care. It can be offering trainings. You all host a lot of work groups, a lot of collaboratives. And so could you incorporate some of the CalAIM, ECM, and community supports into those groups you're already hosting? So just some food for thought here. We will revisit this and look at what some counties are already doing. And I know we have a few on here who have implemented ECM and community supports as a provider. And I'm sure a lot of you are doing referral partner work as well as capacity building. So let's now jump into it. Let's get into ECM, and we're going to start off with another poll. So is your county interested at this moment in time in becoming ECM providers? Yes, we're already contracted. We're in the process. We're not sure, or no, it's not a good fit for us. All right, looks like we've slowed down. Folks, oh no, everyone now is coming back in. So it looks like most of you are in the process of becoming contracted, or you're not sure whether or not it's a good fit, which I think is great. I think just thinking about it, and I know with the budget and some of the cuts that are being made, some counties have been rethinking ECM and community supports to see if that would maybe cover some of the gaps that the budget laid bare. So we will dive into that a bit more. So ECM, this is the Medi-Cal benefit. So this is part of what managed care plans have to offer. It's part of their contract with the state. So what ECM is really trying to do is breaking down the traditional walls of healthcare. So going beyond the hospitals, the clinics, and into the community. So we're really trying to, again, keep things in the community when it's appropriate for folks when they want to do that. Trying to coordinate care. So we're trying to have housing providers talk to clinicians to figure out how do we best serve this member. We want to do that whole person care approach. So what ECM has done is they want to have folks have an access to a single lead care manager who's really trying to get them the care they need, whether it's housing, whether it's clinical, whether it's specialty care, whether it's a wheelchair. We want to have that lead care manager really coordinate their health and health-related services. And again, we're trying to standardize across the state. So we want to see managed care plans offer the same level of services, contract with both clinicians, FQHCs, for example, as well as community-based providers for ECM. So we want to have folks be able to work with trusted providers in their communities they may already be engaged with. So one of the visions the state has, we're going to go back to who costs the state the most for Medi-Cal, is we want to capture folks who are going to be our highest need, most vulnerable, most expensive piece of the population. We want to offer them ECM. We want to help coordinate their care. They have to opt into this, but we're trying to get those folks to come into the system. And a lot of them, maybe if they've been unsheltered, have not been in the healthcare system before. We want to bring them into the system and try to meet all of their needs through ECM, through a coordinated lead care manager. So what they've done for this continuum of care system is they have ECM at the top, serving the highest needs, that 5% of the population that really is most vulnerable, have the most complex care conditions, and cost the state the most. So we have this little pyramid here on the right-hand side of the screen. And then as folks graduate from ECM, or they don't quite meet the threshold for needing ECM, we want to have a step-down program, complex care management, which the managed care plans are required to offer as well. And most of them already do. We may not be aware of it, but they are already offering this. And we're starting to see some of the managed care plans think about this continuum and how do we contract with providers for all three of these services, so folks continue to have that trusted provider they're working with, no matter if they graduate from ECM and step down or not. And the bottom part of this little pyramid is our basic population health management, which I think probably most of us have utilized. It's your wellness programs, your preventative care. That is part of what the large population can access for this care management continuum. Any questions on this? One piece that I want to point out is that ECM is really intended to be a high-touch, person-centered, in-person program. And as we know, if you're in rural communities, that can be a little bit harder to do, but the intent really is to have this be someone who the Medi-Cal member knows, gets to trust them, and really can rely on them to help coordinate and access care. So we're trying to get to that in-person approach. We think about how ECM is administered and delivered. It does start out with the state who contracts with the Medi-Cal managed care plans. And at that point, the state is saying, hey, this is in your contract. I'm going to do oversight over what you're doing. But it's really the managed care plans that are in charge of contracting with the ECM providers and setting their rates. So all the rates are done by the managed care plans. So you will see variety across managed care plans, across counties for ECM services. And then, of course, payment goes the same way. The CBO, who is contracted for ECM, will bill the managed care plans, and the state's not involved in that transaction. So as we mentioned earlier, health homes help the managed care plans start to learn what's required for these types of programs. And over the past 2.5 years, we've seen the managed care plans really learn a lot and step up to try to make this process more seamless for providers, make sure payments are being made in a timely way, and really work with organizations to understand what does it mean to bill Medi-Cal, what reporting is required. So we're seeing a lot of growth. I think we still have some growth yet to realize in this process. There are 7 core services in ECM. One of the pieces that I'm going to emphasize here is going to be our outreach and engagement. This is where we're trying to find folks who may qualify for ECM and engage with them and enroll them into ECM. Some managed care plans are paying for outreach and engagement as a separate transaction from the ECM services themselves. And some managed care plans have a bundle for all of these services. So it really depends on the managed care plan. And Gloria, I see your hand is up.
Hey, I had a question on the previous slide. So in the scenario where a county is acting as an ECM provider, are the county would be contracting with the managed care plan like a community-based organization, or is there a different structure?
It'd be the same structure. So in the example here at the bottom, we could just replace it with county, and then you would be contracting with the managed care plan and billing the managed care plan directly.
Okay, thank you.
No, great question. So back to our core services, we have outreach and engagement. We have a lot of the things that you all are familiar with in terms of doing care management, doing that comprehensive assessment and care management plan, coordinating services, and trying to make sure that we're really coordinating not just the health services, but those referrals to community and social support services. So we're going to emphasize that lead care manager is really working hard to ensure that we are accessing all the services the individual needs, making those referrals, making sure they follow up with the individual to get there. And Tara, I see your hand is up.
Yes, thank you. So I manage in-home supportive services in Napa County, and we have a large percentage of recipients who cannot manage their employer responsibilities. So that's setting up schedules, interviewing care providers, approving time cards. And I'm wondering if ECM is intended to be short-term, or if a recipient might be able to benefit for more long-term, and that these services would be able to assist with those sorts of activities.
Great question. So the intent here is to meet the members' needs. So we have seen members be on ECM for more than 12 months. What's really required is to make sure the managed care plan approves and authorizes ECM. So they have what's called a TAR, a treatment authorization request. And so you have to get that approved. Currently, the state has been allowing managed care plans to kind of set their own timeframes for a TAR. So we've seen some TARs be 3 months, some be longer. The state is trying to emphasize we need to standardize that to more of a 6 to 9 month standard timeframe. But you can do that, and most plans are definitely open to having it be a longer term service. The key question for ECM, which I know for the population you work with can be tricky, is are they in managed care? Great. So that's the first question. If they're not, then it's like, oh, they don't qualify for ECM. But yes, and a lot of those services do fall under ECM that you mentioned. Anybody else have questions? All right. The other piece that we want to see more of, and again, think about a county being this, whether you're an ECM provider or not, is we want to make sure that we are referring folks into these services, referring them into ECM if they qualify, but also into the social support services that are offered through community supports. Some of the most common services that we see for community supports are going to be medically tailored meals or medically supportive food, sobering centers, housing services. And so we really want to think about how do we have folks and help them access these types of services, even if you're not a provider in the county. How do you start to build that referral pathway, that referral network to get folks into these services? And one of the things the ECM lead care manager can do is to make all of those referrals, connect all of the folks to the services they need, coordinate the transitions of care. So if they're coming out of a nursing facility, how do we help them step down into a community-based setting? So really trying to help folks stabilize, get healthy, stay healthy. So who is eligible for ECM? So the state, I think, and was very smart. They started to roll out ECM by what they call populations of focus. And they really started out with those populations that were already doing whole person care across the state. So we could just transition those populations into CalAIM, into ECM. And they've rolled out all of these populations of focus, and they're actually all live right now, which is exciting. But they do have to be categorized. When you're working with someone and you send a referral to the managed care plan for ECM, you have to identify which population of focus they may fall into. And oftentimes they fall into more than one. So it's typically not a challenging thing to do, but we do categorize the folks in ECM by their population of focus. And if you want to learn more about each population of focus, we have a lovely policy guide, which I know is not the most exciting read, but it actually has a lot of great information in it. So I do encourage you all to use that as a reference guide. And I see that Baljeet put that in the chat. Thank you, Baljeet. So as we look at providers for ECM, it's important to understand who can be a provider for ECM. Of course, the state wants us to be all local providers, so we want to have our local organizations doing ECM. That is not the case in every county. And I've had a lot of county folks tell me, I don't recognize the providers who were contracted for ECM. I think that's a problem. And so again, another role for the county could be, do you have providers who you know do good work, who work with these populations that should be an ECM provider? So how do we encourage the right organizations to step up and do this? But what we want to see is community-based entities. We want them to have experience serving these populations of focus. We want to have cultural competency, right? To work with these different groups, to be able to become that trusted person the individual goes to help solve their problems. We want to establish all of that through ECM. What we're starting to see, which I'm very excited about, is at the first part of ECM, we had organizations step up to serve all populations of focus. And now we're seeing, oh, wait, I don't have expertise serving this involved population. So we're starting to see providers start to say, hey, maybe I'm going to narrow my focus to just those populations that I have experience working with. I think that's a good thing, but we also need to have providers step up who do work with these other populations and become those providers. So I encourage counties to think about, who should be doing this work? How do we help them get engaged? And if you're curious who are the ECM providers in your community, the managed care plans are required to post on their website who they have contracts with. They're not always updated lists, but it's a good starting point. We also encourage counties, especially, to reach out to your managed care plans. You can ask for the current contracted provider list, and most of them will send you who they're currently contracted with. So another way to have counties play a role in getting folks into ECM. So how do eligible members access ECM? So we now have providers. How do the individuals get into ECM? And there's pretty much 3 different ways that you can access ECM. You can self-refer. So I could say, you know what? I just got diagnosed with something. I need help managing my care. I can refer myself into ECM. And we're starting to see a lot of providers generate these amazing QR codes that lead you to a self-assessment that can help you identify if you actually do qualify for ECM. So lots of innovations happening to get folks to be able to self-refer into ECM. So that's ideal. The next way we want to see things happen is have communities and counties make those referrals for folks they're already working with. So we want to have counties make referrals. We want to have our housing providers make referrals, our first fives make referrals. We want to get folks involved in making these referrals. I have someone I'm working with. I think they could use extra assistance coordinating care. I'm going to refer them into it. The third way, which has been the predominant way things have been happening, which has not been very easy, has been the managed care plans go through their list of members, and they really try to identify who meets the ECM qualifications. They send out these lists of 100 people to their ECM providers, say, hey, go out and engage these folks and see if they want ECM. We know that has not worked very well. And in fact, in most providers, they get these lists every month from the managed care plans, and maybe 5% of those folks actually enroll in ECM. So that's what's been happening. It's not very effective. What we want to get to is having folks self-refer or have community-based referrals be the normal way. It's going to yield a higher enrollment. It's going to get folks who are already, working with certain organizations to get that connection to a lead care manager. So again, roles for counties, thinking about all these different things that you can get involved in. I do want to point out on the right-hand side of our screen here, we do have examples of referral partners, just to kind of generate some thinking here. So, a lot of the county behavioral health services, you touch a lot of vulnerable populations. So how can those organizations start to make referrals for either ECM or community supports? How do we get our first fives on board? A lot of them do home visiting programs. A lot of them have family resource centers they're funding. How do we help them become those referral partners when they're working with a family who could benefit from extra services? Hopefully we can get them to make those referrals for ECM. We also know that we have a lot of our clinics who can make these referrals, our hospitals, which has been a really important source of referrals, and we can figure out how to get our social workers, our discharge planners to understand ECM and make those referrals. Again, county behavioral health has been a big, potential for referrals. I think some counties have been very successful and others are learning how to do that now. And Baljeet, I see you put in the chat, yes, the state is working on a standard ECM referral form that should be put out soon, but currently each managed care plan typically has their own referral form, but they are often taking each other's referral forms. It's pretty standard information. Elaine, I see you also mentioned that age and disability resource connections are great referral partners. Absolutely. There's a lot of folks out there that, have vulnerable populations they're working with, could be great referral partners. So how do we educate them about how to do that? I don't know, Elaine, if you want to talk about perhaps what you've done or seen with this particular referral partner that has been so successful.
Yeah, because these folks are often referred to the ADRC by counties and by other service providers and family members, and that ADRCs do a complete person-centered intake, and a lot of the services that are provided are things that are mandated for ADRCs to do. So that's a great place if we need to educate the ADRCs on, what that referral looks like and how to be more engaged.
I love it. I think that's the key though. How do we educate folks? How do we train them how to make those referrals? And one of the things that we think a lot about is first fives, for example, ADRCs, and they may know this more than the first fives, but how do we know if someone's in Medi-Cal managed care? And if you have multiple plans in your county, how do we know which managed care plan they're enrolled in? But I think trying to crack these nuts and figure out how to get these folks who are already out in the community working with eligible populations to make those referrals is important. And I think counties can play a huge role in doing that. Thanks, Elaine. So let's talk about more referrals and the role of the MOUs. So we do know that in the MOUs, there is language about referrals for ECM, and that may be helpful in promoting referral relationships. I think it's also going to be important to develop that relationship with your managed care plan and start to work together, not just on the MOU services, but also build those partnerships for ECM, for community supports, for transitional care services. So really thinking about how do we leverage the MOUs to build more to help meet the needs of our individuals we work with. So just want to plant some seeds in there for all of you. So next I'm going to go to some of the emerging practices that we're seeing across the state, and a few of the counties who have shared their learnings are here today. So feel free to jump on board, or folks, feel free to add your 2 cents here as well. But how do we think about as a county, how do we build an ECM program? If you do want to become a provider, you're thinking about it, maybe with the budget cuts, you're saying, oh, how do we continue to fund the services that we're currently doing that may be tied to care management? ECM may be a possibility. So some of the things that counties have shared with me as they've thought about doing ECM, the decisions they've made, which have been, led to success, has been how do we set up ECM? Where does it live in the county structure? Is it a standalone unit? Or is it a unit that's built into the existing organizational charts that can just be part of an existing department? So thinking about how your county could structure it to be successful would be an important consideration for becoming a provider. What is the focus of your ECM? Why are you doing this? Is it to help folks get more stable so they can participate in current services that they're already getting? Is it trying to do preventative services? So maybe we can help folks who may have some mental health needs not go into specialty mental health services. Maybe it's trying to capture them before that point in time to help stabilize them. Maybe it's because you have lost some funding and you want to keep doing some of the care management programs you're already doing, and it could be a way to help fill those budget gaps. Who in the county has capacity for data collection and invoices? So a lot of the challenges we see, not with just counties, but all the CBOs who are trying to contract with managed care plans for the first time, is how in the world do they set up their systems, which sometimes were in Excel. How do we help them start to collect data they need to report to the managed care plans? They need to do the billing, which is really, really important. So we've seen a lot of growth happen with many organizations of how do we develop the systems If you were a housing provider working off Excel, how do you move into billing the managed care plan through their portal? Quite a journey. How do we do referrals and enrollment? Who in our county engages with folks who may qualify for ECM? How do we encourage community partners to refer to the county for ECM? What are those pathways looking like? What you want to find out if you're going to become a provider is how do we have that steady stream of folks that are in our program that we're serving each month so we have a reliable revenue stream through ECM. And then last but not least, financial sustainability is really important. And we have seen a lot of providers and some counties really look at ECM as being part of their funding mix. It's not going to stand up a whole program and support a lot of folks, but it may be a way to piece together some funding to really keep your staff doing the work that's required. We also know that staff can split their time between ECM and other care management activities. So again, thinking about how do we blend and braid funding to really provide enough money to sustain the programs and the staff that we already have. And I don't know if we have any counties who want to come off mute and talk about how they may have set up ECM in their counties. Looking at Tulare. San Diego, Mark, do you guys have an ECM program already in the county?
Hi, good morning, Gretchen. Actually, we do not have an ECM set in our county quite yet. However, I can speak on experience when we were part of the whole person care initiative back in 2016. That's where we coordinated care with our IHSS customers our customers who were transitioning out of long-term care and providing them IHSS services and other referral resources in order for them to sustain independence in the home to get out of that long-term care. As far as that's our experience as being ECM was during that pilot. I'm not privy to any of the new information coming out right now.
No, but that helps. I think you do have experience with whole person care. So how do you build on that to create a potential ECM program? So I think those are good connections to make.
Yes. Well, we did have monthly meetings with our medical care providers. These were folks from our 5 MCP plans that were participating. We had folks from Blue Shield California, Community Health Group, Molina Kaiser, and I always forget the 5th one. But it was really just making those connections with those MCP staff in order for they would tell us what kind of referrals were coming through, what kind of expectations the hospitals had as far as discharging these customers back into their homes, things of that nature. I was really just working within the unit. I wasn't actually the liaison or the pilot liaison to the MCPs, but that was the expectation we had as the social worker unit, was to engage with the MCP representatives at that time.
So thank you for raising that, Mark. That's really important to build those relationships with the MCP, engage them as partners in all of this work. So thank you for raising that and highlighting that. That's really important. Any other counties who want to share their experience either with whole person care or if they are an ECM provider or thinking about it, some of the things that they're processing as they go through the process? All right, well, if no one's going to jump in, we're going to keep moving. But if you have thoughts throughout the training, please let us know. I'd love to hear how you're approaching this work if you are. So the other thing that we want to point out is how do we engage our managed care plans and our AB 2083 system of care? And we know that some counties are already inviting the managed care plans into these meetings, which is exciting. I was actually just talking to Santa Clara earlier this week about what they've been doing with their managed care plans, and they're just starting to have them join their meetings. But I do think it's an important thing to think about how do we engage our managed care plan partners, as Mark mentioned. How do we start to share information for care coordination, whether it's individual or it's, general information. So how do we build these folks in as partners for all of our different programs? And I don't know if there's anybody on from these other that want to share how they've invited the MCPs or why they invited the MCPs into these meetings. All right, well, something to think about, not just with AB 2083, but other meetings you have when the managed care plan can come to learn, can be a good partner. I think it's really important to incorporate them in to our systems. They are here to stay with all these, Medi-Cal transformation programs. So I think it's important to start to build those relationships in a way that makes sense for you and your staff. All right, so ECM enrollment expectations. So let's talk about what those are. There's been a lot of buzz about how we're not enrolling enough people into ECM, which is true. And I think it's important to start to understand where the gaps may be and how can we all as county partners really make a difference here. So if we go back to one of those slides on Medi-Cal, we talked about 5% of members are responsible for 50% of costs. We really want to capture that top 5% of folks with the most complex needs, the most expensive. The state said, hey, that's great. Let's target, 3 to 5% of our Medi-Cal members to enroll in ECM. It's a very ambitious number. We're hovering somewhere around the 1 to 2% right now of enrollment. Again, depending on the population of focus we're looking at. So we do have a lot of work to do, a lot of room to grow into our enrollment numbers. As we talked about earlier, folks can be identified for ECM in many different ways. So if we think about how do we help folks access ECM, looking at how do we help them self-refer so they understand and can access these programs on their own. How do we help our referral partners really start to engage and make referrals into ECM? And I think one of the things that I think it was, Elaine, you mentioned this, but folks who are already doing these comprehensive assessments, how do we add in 1 or 2 questions which may help identify if someone's eligible for ECM? So thinking about counties, who do you work with? Who do you make referrals to? Who do you know are making referrals in the community? How do we help them understand what that ECM program is and how to identify folks that may benefit? And then how to make that referral. So thinking through that is going to be really important. And again, as we mentioned earlier, getting those community-based referrals, that's going to be a higher enrollment rate than if we have the managed care plans comb their lists of members to see who may or may not qualify. So again, this is where I think counties can play a critical role to really help improve enrollment. And what this also does is improves the enrollment and payments for organizations who are ECM providers. So bringing more dollars into the county through that. I'm just making sure, Mark, you got your question answered here about the AB 2083. Okay, awesome. Thank you, Baljit and Andrea, for responding in the chat. So let's look at ECM enrollment. Now, I'm just going to preface this data is old, but it is the most current data that we have from the state on ECM enrollment. We are going to look at it from January 1st, 2022, when it started, to September 30th of last year. And you're going to see we have a nice trend going up. We'd like to see it be a little bit of a steeper trend, but we started out with folks who were in whole person care and health homes being transitioned over to ECM. And then we started to add more populations of focus, started to mention that we got more and more folks enrolled in ECM. Great. If we look at who's enrolled by population of focus, you're going to see our whole person care populations of focus, people experiencing homelessness, our high utilizers. They're the ones who've been enrolled in ECM the most. And of course, as we look at some of the children and youth populations of focus, they just were eligible for ECM typically July 1st of last year. And so with this data, they only had 3 months to enroll. So the numbers are very small for very good reason. Hopefully we'll see those numbers grow as we get more and more data coming out of the state. And then we can look at who is contracted by population of focus. Where do we have providers? And again, we're going to see those whole person care providers who really understood this work They jumped into ECM pretty much and became providers pretty quickly, again, serving those whole person care populations of focus. So we'll see those populations have the most providers. And as you go down and look at the children and youth populations of focus, again, they just launched 3 months before the data was released. There's still some growth here, and I think there hasn't been as much uptake with providers as the state would like. So I was at a meeting 2 weeks ago with the state, and they're talking about how they really want to get more folks who serve children and youth involved in ECM. So there is a big push to do that. And then if we look at the total number of ECM providers by type of provider, you can look at where most of the ECM providers come from. We're going to see the FQHCs, our clinics, are big providers. And the next, or the largest group is going to be our other category, which are CBOs, or housing providers, some of our, community health worker type organizations who are doing this type of work of enrolling individuals into Medi-Cal, and they became ECM providers. So a lot of those types of folks fall into that bottom blue line of other providers. I do want to show you in the middle with the counties. There are not very many counties who at this point in time were contracted for ECM. That's grown a little bit, but not, I think the state would like to see more counties involved. We'll see if it works or not. Any questions on this data? So now let's go back to my favorite slide, what is the county's role in ECM? So you could become a provider. That can be really challenging for counties. There's lots of challenges and sticking points for doing those contracts, trying to get the staff to do the work, trying to make sure you have someone who can do the data, who can build the plans, who can do all of that. So that can be a challenge. But it is new revenue that the counties could be receiving for work that you're often already doing. So there is this balance there. And then I'm going to just thank Baljeet for this bottom bullet here under becoming a provider, because we do think about for children and youth populations, especially, that if you are an ECM provider, you can serve as that air traffic controller for the children and youth and help coordinate their care and all of their services. And that can be paid for through ECM. So just thinking about that. If being a provider is not a good fit for the county, can the county become a good referral partner? Can you make referrals to ECM providers? Can you make referrals for community supports? So how do you do that? How do you train staff to do that? How do you have staff be able to look up if someone's in Medi-Cal managed care, which managed care plan they're with, and then make the referral to that managed care plan for ECM? How do we do that as a county? How do we also ensure that our partners and the community that we work with can be good referral partners? How do they know what ECM is? So again, I'm going to think about the county being able to engage a lot of different providers, whether they're ECM or community supports providers or not, but they have a lot of providers out there. How can you train them to be aware of ECM? How can you let them know how to make a referral? We have seen some counties invite the managed care plans in to do presentations at some of their monthly meetings they have with different providers about what ECM is and how their forms work. That can be one avenue to help grow knowledge about this program. Again, county, you're a capacity builder with one of your big roles. How do you leverage the roles that you have in this way to really encourage ECM, encourage folks to get enrolled into ECM? And Gloria, I see you have your hand up.
Hi, yes. So you mentioned that, the state would like more counties to potentially look at being ECM providers or just have more participation. Can you tell us some of the additional supports that the state can provide to us to walk us through the process, explain how to do it, maybe give us some options as to what county departments are maybe good fits for becoming ECM providers, things like that. I'm just, we're interested, but we don't even know where to start. And I'm speaking from the perspective of, the social services arena that works with the aging population. I know that our health department within our county is an ECM provider, but their scope is very different, social services versus health department. So yeah, I mean, we're interested, but it just seems like this is a really great resource for us. But you know, what other resources are they going to offer to us to help us get to that point?
Love your question, Gloria. Thank you. So I think the state would love to have counties be more engaged, not just as a provider, but also as this referral partner capacity builder. So I think it's the whole gamut here. One thing that's hard, I think, for a lot of us to shift our thinking to is the state is not doing a lot around TA for anybody in ECM and community supports. It's really coming through a couple of different pieces, and the state's funding some of this. But the managed care plans are really great partners, and they really want to grow these programs. And so I think one of the things that most managed care plans do is they have kind of an ECM community supports 101 training they may do. And they may do this monthly, they may do it more frequently. It depends on the managed care plan. So I think that's one option, is talk to your managed care plans. Could they come in and do an info session for your county staff? The other thing that I am going to really encourage counties to think about is the state has funded what they're calling PATH CPI collaboratives, collaborative planning initiatives, and every county has one, and their state has paid for facilitators. I happen to do it for a few counties, so I'm just going to be clear about my my role here too as well. But we really try to raise awareness and bring folks together around ECM and community support. So it's a great way to find out who's involved in these programs in your community, find out kind of where the challenges, sticking points, barriers, funding streams are. So I encourage all of you to look at that, and I'm going to try to get into the chat the link to sign up for that for your county, but it's just one way to do that. Typically, all of the collaboratives have in-person meetings once a quarter, and those are probably the most valuable for you to attend if you were to attend just one. So that's a good starting point, a good resource. And there's a couple of other pieces that I think are really important, which we're going to cover in more detail, but there is some funding that comes down from both managed care plans and the state for startup costs. What's important to know is those dollars are going away soon. And so if you are thinking about becoming a provider, if you have a partner organization who may want to become a provider, it's important to kind of jump in and find out what those funding sources are and when they're drying up. And each managed care plan received a set of funds called IPP funds, or incentive payment program funds. And those, the managed care plans have spent differently. So some plans have a lot of money left they're still giving out, and some have just a little bit they're targeting for certain services. So we can talk more about that. And the state has a big grant called PATH Cited, and there's only one more round of funding for that. And we expect the application window to open in October for that funding stream. Andrea, I don't know if you want to speak a little bit about some of the trainings that we're doing and some of the things that, you know, hopefully we can offer in the future.
Yeah, absolutely. So CFPIC is also trying to become a vendor for that kind of TA for this exact reason. We feel like our counties, we understand their questions because we all sort of come from county life. So we understand the questions, and we understand sort of the intention, what you're trying to gain by becoming an ECM provider, or understanding the role of ECM in your community so that you can lean on your managed care plans to target the right ones and to help those ECM sort of get stood up, so to speak. And so we are actually pursuing some additional funding to continue to provide trainings like this. So we provided CalAIM 101, and this is 201, and we're sort of taking notes all through this series of 201 and are building right now CalAIM 301 that would be a little bit more focused on fiscal strategies or how to optimize all that's available in CalAIM, but particularly how to fund what you want to fund. What are those leverage points? And so it will be a little bit more of a fiscal focus, and we are actually building that right now. We're working on that right now, and we hope to push that out as soon as possible, like August, September, so that we beat those windows that are closing, those IPP funds and things like that. So we're trying, and if we do become a vendor, we will keep this niche going big time and begin to sort of gather counties where they are developmentally and what they're thinking so that we can provide actually on the ground TA to those counties ourselves. So those are our sort of pipe dreams. We hope that we're funded and that we can continue to go forward. But I just wanted to validate what the line of questioning and what you're exploring, Gloria. Just wanted to validate that and just say CFPIC, we want to be a great partner in this work and are building expertise as we go. So yeah, thanks, Gretchen, for giving me that little commercial break.
Yeah. But I think it's important, Gloria, and I think the key for me is that managed care plans are a great place to start. And I think if you let them know you're interested, I think they're going to be very willing to talk with you and point you in the direction for these resources. But the collaboratives are a great way to start to meet other providers and network. So I encourage everyone to kind of look at that. And if you can attend, those in-person meetings they have once a quarter are really, really good. And I have a whole slide, Gloria, I'm going to come to in a little bit, then we'll cover this in more detail so you can have it all written down for you. Great question. So I do want to just highlight that we, as Andrea mentioned, to support everybody for where we are today, we do have TA office hours. We have only had 2 for this round of trainings. We do have just 1 more left coming up next week on the 21st. And what these are, they're 3-hour chunks. You can come whenever you want. You can ask your questions. You can leave whenever you want. It's really a chance for you to come in and say, hey, I went to the training. I had some more questions about the path-cited funding. How do, let's talk about that. And Baljeet and Andrea and I can answer your questions and share with you what we know about these different topics. So I encourage all of you to come. And again, you can just pop in for your 5 minutes and ask your question and leave. No need to come for the full 3 hours, and come anytime during the 3-hour chunk of time. You don't need to be there right at 1 o'clock. And I know that we have the registration links that are coming out as well. So you guys are all ECM experts, right? Now we're ready to jump into community supports. Okay, we're going to do it anyways. And again, we're going to have a little poll to see if anybody is thinking about becoming a contracted provider. Maybe you already are for community supports. Maybe you're not sure about it. And maybe you've already said, nope, it's not a good fit for us, but we'd like to learn more about it anyways. Maybe the poll is lost in Zoom land. Andrea, we can move on too if the poll's not wanting to come up.
It's having an attitude. Yeah.
Okay, we can move on. We don't need attitude. I'm going to guess it's probably similar to ECM. Some folks are like, yes, we're already providers. We're thinking about it. And some folks like, we are definitely not a community supports provider. So we will assume it's similar breakdown. So let's talk about CalAIM and community supports. So community supports, they are not a Medi-Cal benefit. So the managed care plans do not have to offer any of these, period. Medi-Cal members do not have to choose to have these services. So, however, having said that, the intent behind community supports are really trying to offer services that are going to save money down the road. And so if we look at the community supports, there's a lot of housing services, there's a lot of other supports that are really trying to help stabilize folks, which the intent is to save money down the road. So most managed care plans are offering the 14 approved community supports in all of their counties. We do have some managed care plans that are having a hard time finding providers for certain services in some of their counties. So we do have some issues, but I think the intent, and what I've seen from managed care plans is they do want to offer as many as they can in the counties they work in. Managed care plans can add new community supports every 6 months. So even if your county does not offer sobering centers right now, they can add that again July 1st and continue to add services every 6 months. The state does have a lovely spreadsheet they update every 6 months with a list of all services being offered by managed care plan in each county, and we'll drop that link into the chat here in a minute. But currently there are 14 pre-approved community supports in California. And again, you're going to see a lot of housing on here. We know that's a really big issue for a lot of communities. We also have medically tailored meals, which has been the most utilized community support across the state, which has been really interesting. We have asthma remediation. We have some nursing facility transition services, diversion to assisted living. So a lot of different services being offered. And we are seeing, again, as you can expect, a lot of those providers who came from whole person care, those housing providers, they are very much active in providing a lot of housing services across the state. We'd like to see more uptake in some of the other community supports, and the state is really aware of what's not being utilized currently. So similar to ECM, community supports is administered by the managed care plans. The state contracts with them. The managed care plans do not get any extra payments from the state for community supports, where ECM, it's a part of their rate. Community supports is not part of their rate. It's not a benefit. The Medi-Cal managed care plans contract with local organizations. They try to, and the local organizations will then bill the managed care plan. So if we sub out CBO at the bottom here in the example, as you mentioned, Gloria, and put in county, that's all going to make a lot more sense for you guys. One thing that's been really curious, actually in most communities, there has not been as many local organizations who are doing the medically tailored meals, which are most utilized community support. We have a couple of statewide organizations who have really built a lot of efficiencies at doing that particular community support services. So you will see some statewide organizations who have really stepped in to some of these community supports and do a very good job. I know the intent is to have it be local organizations, and we'd like to build that too. So again, thinking about who in your community offers these types of services and who should be getting a contract with the managed care plans and their role the county can play. So here's some data. Again, it's a little bit old from the end of September of last year. We know that in every county, there were at least 6 community supports that were being offered. That's grown since then. 40 counties as of this moment had 10 community supports available, and 12 counties had all 14. We have seen most counties have, probably 10 or more right now. So that those numbers have really changed, which is exciting. How do individuals access community supports? It's a little bit different here, is that they don't have the managed care plans combing their roles to see who may qualify and then sending out engagement lists to our providers. We're really relying on those community-based referrals. So again, counties, you can play a role here in making sure that you refer folks in who may benefit from housing services. A lot of counties have housing programs. So how do we work together with the county programs and the community programs to really provide a comprehensive set of housing services? How do we blend and braid funding? So that's going to be really important. And then, of course, individuals can self-refer in, and the managed care plans can refer. So if they do encounter someone, or they have a provider who mentions somebody could benefit from some housing supports or medically tailored meals, the managed care plans can make those referrals. Questions on community supports? All right, so some of the emerging practices that we're seeing from some of the counties who have chosen to jump in. One of the things I think a lot about is, what are some of the services the county wants to see in their community? Is that a community support service? And so should we try to find a provider to offer that? Should the county become a provider to offer that type of service? So we have a lot of recuperative care programs that are actually housed in the counties that mainly have 10 or 12 beds, and we know we need more. So can the counties become a community supports provider to grow the number of beds for recuperative care, as an example, or rehabilitation programs? So thinking about that as a county, what services do you want to have? What do you want to see funded through the managed care plans? What expertise do the counties have? A lot of counties have housing programs. So can we leverage that expertise, that experience to become a community supports provider? And the other thing that I've had a lot of counties talk to me about is just community supports gives them a chance to work with the managed care plans to prevent duplication of efforts. So instead of having 2 parallel programs running and competing with each other, could we start to work together to really be a more comprehensive approach for housing, for example? That's the one I hear a lot about. So we're not all chasing the same landlords down. Could we start to coordinate our efforts a little bit more? So thinking about that. And then our favorite thing, the budget cuts. What are the gaps that are going to emerge in the next year because of the budget cuts? How can we fill those gaps, perhaps with community supports funding? So thinking through all of those possibilities. Any counties want to share some of the things that they've been thinking about for community supports, if they're thinking about becoming a provider or just trying to encourage local providers to jump in? Okay, well, if you want to share, feel free to down the road. Let's talk about the different community support services and really look at what's being offered. So let's start with our housing suite of services. I think this has been one that has been heavily utilized, again, a rollover from whole person care for a lot of communities. There are different housing services. The most common one you'll see is the housing transition navigation services. So we're really trying to find housing for folks. And that includes getting folks housing ready. Maybe they need an ID. Maybe they need help, getting those deposits for the applications. Maybe they need help with landlords to, apply for housing. So how do we support folks in doing that? That is part of community supports. We also have what's called housing deposits, which has been heavily underutilized. So the state's been really trying to understand why that's happening. But this is deposits that can be used to help secure a housing unit, help with utilities, first and last month's rent, really trying to help folks get into a housing unit. The challenge has been that it's once in a lifetime benefit, and the minimum is $5,000 someone can use. We see some managed care plans increasing that amount. I've heard some managed care plans offering $8,000. So again, depends on the managed care plan, but really trying to get folks into housing. One of the challenges that we hear with housing deposits is which CBO can front $5,000 for multiple organizations and wait for the managed care plans to reimburse them. Not very many, right? So I have seen a couple of counties say, hey, we're going to step in and fill this role. We're going to become just a housing deposits community supports provider because we have somewhat deeper pockets and have more tolerance to wait for reimbursement than our small housing CBO. So I have heard some counties thinking about doing that, and some counties are actually doing that. So again, some food for thought there. We also have housing tenancy and sustaining services. So once somebody is housed, how do we keep them housed? So how do we work with landlords? How do we troubleshoot issues? How do we advocate for them? And again, think of the different populations that you guys work with and who may benefit from these types of services. The two other housing services are recuperative care, as I mentioned, which is for someone who is coming out of the hospital, for example, and may not need hospital level care, but needs a safe place to rest before going back to the streets. That can be recuperative care. A lot of communities have just a few beds. We want to see those beds grow. We know there's a need for them. So really trying to look at who is the right provider for that. And this has been a really hard one for managed care plans to find providers for outside of often the county. Short-term post-hospitalization, again, this is interim housing for folks who may need some time to recover after being in the hospital. They have, behavioral health issues. They need to stabilize a little bit. So looking at how do we involve all of this. And again, counties, you often have housing programs. And so how do we coordinate care amongst all of them? How do we coordinate funding? So we know for some of like the housing deposits, once in a lifetime benefit, are there other funding options to help folks get into a housing unit that could be used first in the county and then using housing deposits as a last resort to help someone get housed? So thinking about how do we coordinate not just the services, but also the funding to really maximize the resources that do exist. Any questions on housing?
And I just want to chime in on that because I was typing that up as you said it. So thank you, Gretchen. It's, Home Safe is a program that we've been informed the funding around that isn't maybe going to be there anymore, right? And so counties are looking at how do you continue to support that, which I think for our aging population has been a great resource. A program that's dedicated, a housing program that's dedicated to them. And so this could be an opportunity for a county to look at, well, maybe we could become one of these housing community support providers to continue that work. So looking at those opportunities as well.
That's really important. And I think a lot of those programs are, being cut. And we also are seeing some counties trying to shift their funding with community supports coming on board and organizations be able to get different funding streams for these services. How do counties take their dollars and leverage them for different purposes? So a lot of things are changing in housing. And so thinking about how do we coordinate all of the efforts is really important. For all of these services, I do have detailed slides in here with the definitions and what's covered here. So if you don't want to read that fabulous community supports policy guide, we do have most of the information in the PowerPoint for your reference. I just know a lot of us have information overload, so I don't want to go through each and every slide in great detail, but they are here. Just for you all to be aware of. One thing that I want to just spend a moment on is the housing deposits. One thing that's coming, we think January 1st, is the 15th community support, which is going to be transitional rent. And that is where the managed care plans can opt in to pay for 6 months of rent for an individual. Amazing, wonderful. I hope managed care plans take advantage of this. But again, we go back to the challenge of who has the pockets deep enough to cover 6 months worth of rent and wait for reimbursement. And maybe the plans will not do a reimbursement-based system for these types of services anymore. But I just, again, want to plant the seed for counties to think about with transitional rent. How does that work? How could we start to become a provider for that? Housing tenancy, we kind of covered a lot of this. I just want you to know that they're all here and they all have great details. So feel free to look at these slides. And I think there's one other piece I want to talk about for recuperative care, which is looking at the context of recuperative care and our housing suite of services. And so looking at how do we think about this? How many of you guys have recuperative care in your county programs or in your county at all? Some may not. Again, it's a really important part of our housing. So it's really trying to capture folks when they leave the hospital, don't need that medical support, but need a clean place to stay until they go back on the street. They may have an open wound. They may have an infection. They're still trying to stabilize. So thinking about that, that's recuperative care. But it really becomes part of this continuum of care for our folks experiencing homelessness. And I think it's a really important service to look at. Many counties have programs. A lot are run by the county, or some cities are running them. Some are done by private organizations, but we do see a need for more beds in this type of a setting. The recuperative care model varies tremendously. What's required for community supports is really interim housing with meals and monitoring for medical and behavioral health issues. A lot of our programs offer significantly more. And again, if you have someone who's in this interim housing, they could be there typically up to 90 days. You can have other providers come in and help them work on getting housing and having another place to go to besides the streets when they leave recuperative care. You can have your lead care managers for ECM come meet with them on a consistent basis. So sometimes these recuperative care services are really great points of contact for getting folks into other either medical services or social services. So another piece of the puzzle here. And then the short-term post-hospitalization, again, another piece of the continuum for services. Oftentimes folks will leave recuperative care and go into short-term post-hospitalization housing. So you can see how people are stepping down into the different types of services here. Then looking again at how we approach housing for most of our California programs, it's a housing first model. We want to provide case management and stabilization services, and we want to hopefully link folks to long-term support. So again, if they're being housed in some of these programs, is there a way to start to work on getting them a more permanent housing unit? So that's one of the goals here. So again, county roles, thinking about for the housing suite of services, what can the county do to help promote these? Becoming a provider, that referral partner is really, really important. You guys know of folks who could benefit from housing support. So how do we start to make those referrals? How do you have your community partners understand these services exist, how to make referrals into it? So again, your capacity building role as well.
And I just want to add, especially around all of these housing programs, the three traditional ones and then the ones to continue to support people coming out of facilities and needing more healing and health related. They call out in the policy guide, it calls out eligible populations and it calls out our exiting foster youth, in particular as folks that are leaving a system of care like child welfare, like the foster care system. And so they are seen as an eligible population for the short term and the recuperative care as well. So I just wanted to call that out.
Thank you, Belgie. So I was thinking we could do a break next. Does that work for folks? Take a few minutes to recharge, get some more coffee, and then we'll come back and do more community supports. We have a lot more to get to. So let's do a 10-minute break. It is currently 10:20, so come back at 10:30 and we can resume our community supports. And a few of the, thank you, Andrea. A few I'm going to really dig into a little bit more, as I think they'll be very relevant for the groups you're working with here. So bear with me as we get into the details. So let's go to our services part 2. These are 3 services that are community supports. We are seeing asthma remediation as being a big service that has been underutilized. So looking at how do we increase utilization. We do have sobering centers, which we know funding dried up many years ago for those. We're seeing a few of them come back, and the health plans are really trying to find providers to offer those services. And then medically tailored meals, that has been the biggest community supports that we've seen so far. And actually one health plan has been driving that utilization. So very, very interesting. It's been fun to watch them roll these services out. So let's just quickly go over asthma remediation. It's really trying to help make the homes safer for folks. And so looking at how do we do home modifications for asthma? How do we prevent acute asthma episodes that could result in the use of emergency services or hospitalization? And so how do we really make that home a safe place for folks? So there is some money tied to this to help with buying buying allergy appropriate things, having cleaning supplies, air filters that will really help with asthma remediation. So looking at that, we do have the eligible populations here. So again, some of you may recognize and have folks that could benefit from this community support service. So thinking about how do you get folks into the services they need. Sobering centers, again, we're trying to help folks. This is not drug treatment. This is not rehab. This is really trying to have a safe environment for folks to sober up, and trying to, again, keep folks out of expensive institutions like the emergency room or jails. So trying to have a sobering center. And again, there could be a potential to work with folks to get them into services they may need, but it really is trying to give folks a safe place to sober up. Then last but not least, I do want to just touch on medically tailored meals and what they are. They are having meals delivered to somebody's home after hospitalization. They are meals that are delivered to help with folks' unique dietary needs. And so this is really, really important. And the service has been really heavily used. And I think there's even more potential for growth. We also are seeing this service offer medically tailored groceries, food pharmacies, et cetera, et cetera. Again, we've seen a couple of statewide providers really excel in this, but the state would like to see local providers as well. So we do have some counties that have a few local organizations who are doing this. We do see some Meals on Wheels programs that have become community supports providers as well. So again, thinking about what's in your community, what you would like to see being offered, how this could help the folks you work with. Medically tailored meals is a really great community support service. We have a lot of details here about the service requirements, the limitations, all of that good stuff. But I think key is that this can really help a lot of folks, especially folks that are newly diagnosed with diabetes really stabilize. And we've seen some organizations, they are serving one member in a household, but as other folks realize the importance of this, that has been expanded to cover other folks in the household. So it's been a really great service. Questions on medically tailored meals? All right, so we're going to dig into our next part 3, which we're going to spend a lot of time on. So I think this is relevant for a lot of folks here today. And this is where Baljit's going to jump in and really offer some more detailed explanations of some of these services and how they apply to county programs. So we'll welcome Baljit here. So our part 3 community support summary is looking at the different options that we have about getting folks who maybe have been homeless, who may have been in an institution like a nursing facility, who are trying to come back into the community, into a safe environment. So looking at how do we support them, not just with the transition, but also with identifying where they can live safely and effectively and where they would like to live. So looking at all of that. So let's start with respite services. And these are really short-term respite services for caregivers. If we look at eligible populations, it's caregivers who live in the community. It could be applicable for some children and youth. So thinking about the populations you may work with. Let me go to the next slide here. And so this is just a way, again, we're trying to keep people in the community, keep them at home. We want to give some respite to their caregivers. And so this is community support services. The services being offered can be overnight stays for respite care. It can really help people attend to the members' self needs and other activities of daily living. So these are some services that are important and again, maybe eligible for the populations that you work with.
And I just want to add, oh, I'm sorry. We're really still trying to understand this community support for the child welfare population because it does call out foster care beneficiaries in the policy guide, but there isn't a lot of information around, well, what does that mean? So we are still trying to understand it. I have not heard of any providers step up to take on foster youth as a caregiver respite community support provider. But if anyone else has heard of one, I would love to hear more about it. And if you've utilized this service for your foster youth population.
Any counties out there who have used this? Let's see if we have any takers here. All right, so we'll move on to rehabilitation programs. Again, another really important service that it's trying to assist the member with self-help and socialization and be adaptive. It can be in a member's home or an out-of-home non-facility setting. So again, we're really trying to keep folks in the community, help them be successful in the community and where they're choosing to live. And so we're trying to improve care coordination and management with rehabilitation programs. We're trying to help folks learn how to use public transportation, how to do have skills with conflict resolution. How do we help them with daily living skills? So again, we've seen this used for a lot of folks who may have been recently housed and may need some assistance in learning how to be successful in their community housing. And Baljit, do you want to jump in with your ILP program comment?
Yeah, so when we first looked at this community support, it just screened our ILP programs that we have in the counties. And I know a lot of you in your county either provide this service yourself through your ILP teams or it's contracted out. And so this might be a way to build local capacity for this particular community support. I could see even THP Plus programs coming on to provide this as a community support as well. So it's not just limited to ILP programs.
And folks that are eligible for rehabilitation, it's folks who have experienced homelessness or who have exited homelessness and entered housing in the past 2 years. So again, this could be a really important service to help folks stabilize. And then folks who are at risk of becoming homeless or institutionalized. So this could be really important for preventing homelessness as well. Our next community support service that we're going to spend some time on is our nursing facility transition and diversion services. So we're really trying to keep folks in the community, again, that tenet of the CalAIM Medi-Cal transformation. So we want to help folks identify where they can most safely live, where they would like to live. How do we help them assess their housing needs and what options are available to them? How do we help assist them in finding a residence? So all of that's going to be part of nursing facility and transition and diversion services. There is some money associated with this community support that can cover some ongoing expenses for members who are living in an assisted living facility. So how do we access that? And again, a lot of these monies are once in a lifetime benefits. So making sure that we're aware if we do utilize these services that we're not harming folks with any future needs they may have. So how does this all work? So we really want to, again, keep folks in the community, keep them out of the highest level of care if they don't need it. So have them live in the most appropriate level of care. And so what we're trying to do is work with folks and provide those wraparound services like companion services, medication oversight, assistance with their ADLs. So looking at how do we do that in the least expensive, least restrictive setting. So who is eligible for this community support? So for the nursing facility transition population, we want to have folks who have been in a nursing facility for 60 or more days. They may be willing. They want to live in an assisted living facility and they can safely reside in an assisted living facility. For the diversion, so trying to keep folks out of the nursing facilities, we want to have, again, folks who want to live in the community, who can safely reside in the community or in assisted living, and who are receiving medically necessary nursing facility level of care and can, meet that criteria for medical necessity. So what are these types of services? What do you guys think would qualify under this that you may already do as a county? Baljeet, you can't answer first. We're gonna have somebody else answer what some of these services are. So I know counties do a lot of this work already, right? You're already helping folks, you're already assisting them, trying to help them find the most appropriate housing. All right, quiet group today. Baljeet, do you want to jump in here?
Sure. Just think about when someone is coming out of a facility, what kind of improvements or changes they might need in their home to make it a safe and comfortable environment for them. What other kinds of additional supports they may need, that you can definitely utilize this community support to help you with that kind of work with your IHSS program or your APS staff to kind of help transition that person back into the community, into the local community as well. Because I know for a lot of our rural counties, a lot of times our community members are having to leave their community completely. And so bringing them back, and how do you do that successfully?
And one important piece for all of these community support services is these are not intended to supplant existing services or funding for individuals. This is to supplement them. So we're trying to figure out, again, how do we break down silos? How do we coordinate care? How do we become more efficient with all of the resources and make sure we're not duplicating that? So our next community support service is our community transition services, nursing facility transition to a home. So again, trying to find that most appropriate level of care for an individual, keep them in the community as long as it's safe and they want to be there. There are some dollars associated with this community support service to help folks with their setup expenses. So if we think about perhaps housing deposits for that community support, there's a lot of similarities to this for our folks transitioning from a nursing facility to a home. And again, we want to make sure the member wants this and they can safely reside in their home. Those are key components to this particular community support service. And so again, a lot of the housing things that we see in our other housing services will apply here, trying to assess what the members' housing needs are and what the options are that are available to them, helping them search for housing and secure any housing units, working with the landlords, and again, trying to help them retain housing. So once they've moved in, how do we help them keep their housing? How do we engage with landlords? How do we work to make sure they have the right supportive services they need to stay in that housing unit? And then if there are needs for additional modifications to the home, that we are coordinating that through this community support service. Again, there's another community support service that does have additional dollars for those modifications. So how do we, again, pull together all the available resources and coordinate them for the members to effectively stay in their home? So this covers, again, very similar to housing deposits, but really tied to the specific population who are coming out of the nursing facilities, security deposits, some utilities, home modifications. There could be some need for some issues like pest eradication and cleaning prior to folks moving in. So thinking about how do we coordinate that and making sure the home is ready for them. And then looking at, do they need some special furniture like hospital beds or other types of things to help them safely stay in that home. Who is eligible for these types of services? So we're looking at folks who are receiving a certain medical level of care but who want to transition. So that's, again, really that patient choice is really important for this community support. We want to have folks who have lived 60+ days in a nursing home or medical respite setting, and who can move back safely into the community. Any questions on this community support service? Again, we're not trying to supplant other existing services, we're trying to supplement. So thinking about how do we use these services, these available dollars to really help folks transition and stay in the community.
And I just added it in the chat, but also think of our medically fragile children and youth that we work with in child welfare, either through the case or even a referral, right? That this might be a way to assist the family in allowing the child to return to the home and to be safe when they returned home from a medical standpoint, not from an abuse and neglect standpoint, but just having the right equipment and set up for the child to come home.
No, thank you for clarifying that. All right, next community support is our personal care and homemaker services. And we have seen a couple of statewide organizations do this and do it very well across counties. I think we're starting to see a few more local organizations step in, but it's been an interesting evolution with some of these organizations who have grown to be statewide. So personal care and homemaker services, it's really helping folks with their ADLs and who want to, again, keeping them in the home in the least restrictive level of care. So it can be helping them with house cleaning, laundry, grocery shopping, those types of services. And I think this is really important to talk through for the IHSS folks here on the call today. This is, again, we're not trying to supplant any service, we're trying to supplement. And so for members who have been authorized but are in that waiting period for IHSS, this can be a gap filling service as well. It can be for folks who are not eligible to receive IHSS. And it can really look at folks who have exhausted all of those benefits. So again, trying to fill some of the gaps for individuals with IHSS. Who is eligible for this community support service? So folks who are at risk for hospitalization or institutionalization in a nursing facility, have functional deficits and don't have an adequate support system, and who have been approved for IHSS. Want to make sure that we're being very clear that we're not trying to, again, take over our, get folks who are qualified for IHSS out of it. This is really trying to supplement and fill gaps with IHSS. So we don't want this to be utilized instead of IHSS. That's really important here. And we want to make sure that we're just looking at all of the different programs for folks and how do we blend and braid services? How do we serve the whole person with what's available? So this is, again, trying to think about breaking down silos, talking to each other, all of that good stuff. Any questions on the personal care and homemaker services? All right, now we'll go into environmental accessibility and home modifications. And again, this can really help support some of the other community supports that we've talked about. It can also be a standalone. So we're really trying to make adaptations to a home to make it safe for an individual to continue living in the community, living at home. So this can include grab bars, ramps to somebody's home, widening the doorways for wheelchairs. So all of this stuff can be included under this environmental accessibility and home modification community supports. There are dollars tied to this. Of course, there's going to be limitations to that in terms of once in a lifetime benefits. But this is really a really great way to help folks stay in their homes longer. And it's not being utilized as well as the state expected it to be. So again, room for more referrals into it. So if you think about folks you work with, could this be an important support program for them? Who is eligible for this? Again, we're trying to keep folks out of those facilities, out of the nursing homes. So how do we keep them in their homes longer? How do we make it safe for them to stay in their homes? That's really what we're looking at. There are some restrictions for this community support service that I think has contributed to it not being as heavily utilized as possible. One of the big things we've seen is that in order to get authorized for this, providers do have to submit to itemized bids from different service providers, and that can be a pain for a lot of folks. So figuring out how to do that efficiently has been a challenge. And so looking at all of these different restrictions is important before you jump into doing this. Questions on home modifications? All right, so I'm going to just do another summary slide here, just so we're thinking about all the different populations that these Part 3 community supports may benefit. So again, respite services, looking at folks who are keeping them in the community, looking at potentially some children and youth who may qualify for those respite services. Day habilitation, so we're trying to help folks learn some important skills to continue living in the community, especially folks who have been homeless or are currently homeless. The nursing facility transition, diversion, folks who are able and willing to live in assisted living settings and can do that safely. How do we support them in that? Our community transition services is how do we help folks who are able and willing to live in the community to stay at home. So thinking about IHSS and APS and medically fragile children may be eligible for those services. Personal care and homemaker services. And again, we're not trying to supplant IHSS. We're trying to supplement, fill those gaps. It's really important. And then home modifications, looking at how do we make the home safe for an individual to stay living there longer. So if there are no questions, we'll start to look at our community supports data and see where things are. And again, our data is going to be old, just like with ECM. So it only goes through September of last year. But if you look at this trend here, we started out with the program in January of 2022 with very few folks enrolled in community supports, and thinking these are mostly whole person care and health homes populations that rolled over. And we've seen a nice steady increase, and we'd like to see that trend continue in the same way. It becomes steeper if possible. We know folks can benefit from all of these services. We just need to get them into the services. Now, what's important about community supports is that folks do not need to be enrolled in ECM to get community supports. So they're two distinct programs and potentially populations. So you don't have to worry about someone's eligibility for ECM to refer them to community supports. Another important thing that we've been hearing about, which is interesting, is you don't have to have the same provider do community supports and ECM. So there may be providers out there who really specialize in personal care and homemaker services. They do not need to be tied in any way, shape, or form to the ECM provider the individual may have. They're very distinct services. If we look at which services have been utilized, again, we're going to see medically tailored meals, and then we're going to see the housing suite of services. Those are the ones that have been heavily utilized. Again, that whole person care rollover has been driving that. If we look down at the very bottom with the home modifications, we think there's more potential for growth here, and there may be some challenges that are from the policy perspective, but I think we'd like to see that be more heavily utilized for folks who could benefit from that to keep them in their homes longer. If we look at the providers who have been in contract and for which services they offer, again, the housing providers, rollover from whole person care, have been driving a lot of these services. All right, let's look at who these providers are. And we're going to see at the very bottom, those other category, which is really our CBOs out in the community doing most of the housing work, the medically tailored meals work. So those are the ones who are the most common providers. Again, if we look at some of the county folks, not a lot of counties are doing community supports. Again, that may change. We're starting to hear a lot of the housing programs start to work more closely with county housing providers to think about how do we really come together and serve folks as a whole and not as separate providers with different funding streams. Any questions on community supports? Again, if you want to ask questions, you have thoughts, you want to cover these slides again, we do have a TA session. I thought it was next week, but it's actually Friday. Friday afternoon, so you can come join us, bring your coffee, you can jump in at any point in time to ask questions, we can cover slides, we can show you the policy guide, etc., etc. So pop in for 5 minutes, 10 minutes, whatever you'd like, anytime between 1 and 4 on Friday. Now we're going to jump to transitional care services. And this is a really important service, and I think that it's starting to get more attention, which is good. We do want to spend some time on it. I was just at a state meeting 2 weeks ago, and they spent a lot of time on transitional care services. So I think they want to increase awareness of what this is and who's responsible. So we are trying, or the state is trying to really support folks as they transition from one level of care to another. So what does that entail? How do we support them in becoming stable in their new environment? How do we support them in being successful with that transition? And so looking at doing that. This is actually stemming out of a program the state has put together called the Population Health Management Program. And it's really trying to have this comprehensive statewide approach to serving folks. It's trying to standardize risk assessments, trying to standardize care plans, et cetera, et cetera. And it's not fully launched yet, but they are trying to do this. And we're trying to really create standardizations no matter what county you live in, which managed care plan you're working with or enrolled in, that you can get the same level of care. Briefly, just so you kind of understand some of the framework here for the Population Health Management Program, we're trying to really, there's kind of 3 buckets they're looking at, trying to gather member information. So what types of assessments are being done, what screenings are being done, what claims and encounter data is being submitted to the managed care plans to the state. And then again, we're really trying to standardize risk assessment across all the managed care plans, and really trying to differentiate who are those highest need, highest risk members of managed care, and the lower risk ones, so we can target the ECM, those really high care coordination programs, to those highest risk members. And then if we look at some of the services here under providing services and supports, we're trying to do that care management continuums, looking at ECM, looking at care management, looking at basic population health management, and of course, to help folks transition between all of those, the transitional care services. The goals for transitional care services is that folks can transition to the least restrictive level of care that meets their needs. they want to live in. And again, we're trying to help folks stay in the community as long as possible. And if they're transitioning out of the facility, trying to help them transition successfully. So coordinating those services, providing that support, connecting them to services in the community that will help them be successful. Again, there's a lot of detail on these slides, great reference point. I don't want to overwhelm you all with details, but very, very simply, the state has done transitional care services in a staggered manner. They started out in January of 2023, trying to say, here are the highest risk members that we really want to make sure are receiving all of the transitional care services. Those folks are going to have a single care manager, a single point of contact that will really help drive their transition, make sure they have all of their assessments done, all the services they need are arranged, all that good stuff. And then January of 2024 of this year, they started to roll out these services for members who were lower risk. So again, some definitions around who's high risk and who's low risk. And you will see populations you're working with. So if we have folks that are in the SMH or SUD population, those are considered high risk for transitional care services. So if they are transitioning between levels of care, they should have one single point of contact to help with that transition. Ideally, these folks are also an ECM, and their ECM lead care manager is that point of contact to coordinate their transitional care. If folks are not an ECM, we should look to see if it's an appropriate service for them and get them enrolled. That will really help them coordinate their care. Lots of details here, really important stuff. I'm going to continue moving forward so we can have some good conversations about counties' roles and funding for counties to jump into all of these services. So if we're looking at transitional care services, the high risk members and the lower risk members, I think this is really important to understand what these services are for each risk stratification and who is responsible for doing all of the work here. And again, if folks are on ECM and they're a high risk member, that ECM care manager should be their point of contact for all of the transitional care coordination. If they are not an ECM, then it falls to a care manager, which can be assigned by the managed care plan, which can be assigned by their clinician. It really depends on where they are coming out of. Any questions on transitional care services? I do want to promote this. So if you have folks who are transitioning between levels of care, it's going to be important to think about how do we get them the care they need. If they're high risk, who is that care manager for them, that one point of contact? If they're lower risk, they still should be getting some coordination of services. So who is that team that they've been assigned to help support their transition? So just be aware this is out there. It is really important, and it's part of our Medi-Cal transformation initiative. All right, so let's go talk about the roles for counties and all of these three programs that we've just become experts in. You can become a provider. That's an easy one to think about. We understand what that looks like. You can choose to be an ECM provider. You can choose to be a community supports provider, even for just one community support service. Again, focus on housing deposits for counties to think about. So counties can become a provider. I think counties are incredible referral partners. And so thinking about how do counties do this? What are the pathways that need to be laid out to become those referral partners? How do we train staff to be aware of these programs, identify who may be eligible, and make those referrals into all of these programs? One thing that we've seen, again, with transitional care services, we just talked about it, but making sure folks are aware these exist and they are important services for individuals that they can get paid for through managed care. If folks are not in managed care, they do not qualify for any of these services, and that's an important piece to think about. And then how do counties grow capacity? How do we help facilitate understanding amongst our broader community partners about ECM, community supports, transitional care services? How do we help folks understand what these services do and how to make referrals into it? How do we construct referral pathways? to do this? How do we bring more dollars into our counties by ensuring that our top-notch providers have become contracted ECM or community supports providers? So thinking about all of that is going to be important. Another piece that we hear a lot about is how do we share data amongst all of our providers for care coordination, for ECM, for community supports, and for other programs. Some counties have chosen to opt into this role and have created, different levels of, I'm calling it the SHE, and I cannot pull up the acronym for me, but I think the Social Health Information Exchange, there we go, types of programs for that to really help to build some data sharing programs for non-medical providers. Some have included the clinical providers as well. We do know that the managed care plans are being required to have closed loop referral systems in their managed care contract for next year, for 2025. And so again, I think it's important for counties to understand, what does that mean? How do we get involved in those conversations? How do we help influence some of the decisions being made around what is a closed loop referral system? How does that work in our county? So want to flag that role as well. So now, how do we know what is needed for all of these programs to be successful? How do we know what's already happening? And I think what's been challenging, I know, for a lot of social service agencies and counties is that you weren't included in those initial conversations around ECM and community supports. So now you're coming in where things may already be happening in your county. So I think it's really important to understand, for the populations you're working with, who are those ECM and community supports providers that are already contracted in your county. And so again, as I mentioned earlier, the managed care plans are required to post lists of contracted providers on their websites. Many are out of date, but again, a way to build that relationship with your MCPs is to reach out and ask for an updated list. Most will be happy to comply with that. And then you can assess as a county who is already involved in ECM and community supports, as a provider, as a referral partner, as an important community partner. Maybe there's some foundations that should be part of these conversations too, to help fill in gaps with funding. How do we invite folks who are missing to the table? I think, again, what is the table? Who's hosting the table is also an important question. We do have these county collaboratives that are being funded by the state to bring enhanced care management and community supports providers together. So that is one table. I know other counties are hosting provider forums for ECM providers who are serving a certain population of focus. So we're seeing different groups come together to support each other. And so thinking about, how does the county get involved in those conversations? And then capacity or saturation. How do you know if you have enough providers in your county for each population of focus, for the population of focus that you work with as a county? So understanding what is capacity is really important. Sometimes we don't have enough people coming into ECM, for example, to really fill up the current provider's capacity. So we need to make more referrals, identify more folks who could benefit from ECM and who qualify. If we don't have enough providers in a certain population of focus or community support service, how do we help those providers jump in and become a contracted provider with the managed care plans? What does that take? Is it a funding issue? Is it a knowledge issue? Is it a issue that they don't have the capacity as an organization to do the Medi-Cal contract, which we've heard a lot about from providers? So how can counties assist with that? Then last but not least, as a county, you understand what services are out there and what's missing. So how do we start to fill those gaps in of what services are missing? Can ECM and community supports help fill some of those gaps? If there are funding issues, could becoming a provider help to fill some of those funding gaps that are potentially growing with the budget? Most importantly, I think it's going to be key to engage your managed care plan partners in your conversations and the work that you do. I think you have the MOUs, which will drive some relationship building with the managed care plans. I think it's also important through ECM and community supports to start to build those relationships as well. They want to work with you for the most part, and I think there's a value to having you all work together, coordinate care. I also think as managed care plans get some funding from the state, having a voice at the table of how those dollars are spent will also be really, really important. Questions on this slide, then Jackie, I'll come to your question in the chat. All right, Jackie, you were asking, can you please explain a little more about closed loop referrals? So this is a wide open question here of what this looks like. Typically, what we're trying to do with a closed loop referral system is that if I make a referral to community supports for Baljeet, for example, that I can trace that referral to see, did that get approved by the managed care plan? Who is Baljeet's provider? And did Baljeet get the service that she needed? So we're trying to have that traction going through. What that looks like is probably going to vary by managed care plan and by community. But the intent is that you can really follow a referral through the system. Does that make sense, Jackie?
Yeah, that makes sense. The part that I was trying to understand is that I'm hearing some of our MCPs say that there's a requirement to have something in place by January of 2025. Is that a statewide requirement?
So the state is going to require that through their managed care contracts with all of the plans.
Okay.
I think what I don't know is what does that actually mean? So what are the minimum standards the state's going to require for a closed loop referral system, and how does each plan respond to that? And if you're in a county with just one plan, it's probably a lot simpler what that's going to be. If you have multiple plans like San Diego, Sacramento, LA, it's going to be a lot more challenging if you have different systems being implemented by the different plans.
Yeah, we have 3 in Santa Clara County. So, and it sounds like the closed loop referral implementation for the MCPs is not going to be different for each of the services. So it's going to be the same for all populations of focus in terms of how they implement the referrals. Because one of the initial thoughts I had was to include something about a closed loop referral type of system in the child welfare CalAIM MOU that we're doing, but it sounds like that's going to apply across the board, whether it's child welfare, whether it's IHSS or whatever else. So I'm not sure that it makes sense to include anything about closed loop referrals in the child welfare CalAIM MOU, only because it'll be a statewide requirement that they have with DHCS, if I'm hearing you correctly, right?
That is the requirement. Again, how
Okay.
implemented is going to be, it's going to vary between each plan. Now in Santa Clara County, the 3 plans often work together that you have and do a lot of collaboration. So I think it's a great question to ask them and see where they are with that and how coordinated they're going to be. Because there may be some elements that it's really important to you to have in a closed loop referral system. So finding out if that's going to be part of the statewide requirements or if you need to add additional things into the MOU, I think will be good to understand. And I don't know, Andrea or Baljeet, if you have more thoughts on this with the MOU conversations you've been in.
Just around the closed loop referrals. Yes, I think if I remember correctly, I think we stricken out the language around the closed loop referrals until, like you said, Gretchen, that the state kind of gives us more guidance and direction on it. So I'm sure it's going to be part of the conversation, if not now, later.
That's really helpful.
So the statewide requirements are coming from DHCS? Okay.
They'll be part of the managed care plan contracts for 2025. What I don't have insight into, and I don't know if it's actually been made public yet, but what those requirements will be. What are the minimum requirements the state's going to put into the contract versus what we all want to see, which is probably not realistic, where we can all talk to each other and refer to each other. That would be great, but I think for you, Jackie, the different plans and how they're going to implement that is going to be the tricky part.
Yeah.
But I know they collaborate a lot on other things, so hopefully they will do some collaboration around this as well. We'll keep our fingers crossed.
And I think we're into 2.5 years of CalAIM going live, right? So it started January 1st, 2022, I think it was. And the state has learned a lot around this entire process of when you give kind of minimal guidance and then allow for each managed care plan to kind of run with what that guidance is. We have seen the state kind of step in and say, wait, hold on. Let's add some more guidance and direction on the original guidance that we gave you. And now we're requiring this and you cannot change this. For example, I guess some managed care plans were changing the eligibility criteria around who was eligible under a population of focus for ECM. The state then provided more guidance around you cannot change the eligibility requirement around who's a population of focus. And they're now coming into, again, more around maybe we do need some statewide things that because it's so confusing if we have 58 different ways of doing this times how many managed care plans you have in your county. So they're now also coming out with a statewide ECM referral form that each managed care plan will have to utilize instead of the ones that they've created themselves. You know, and this all these changes where the state kind of decides that they need to lean in more after they've already kind of put out finalized versions of guidance, MOUs, whatever. It's all coming out of these collaborative planning meetings that Gretchen mentioned earlier. So I learned about this earlier this year, is that after each of those meetings, the contracted consultants that facilitate those meetings have to report back to the state what came out of each of those meetings. And then state staff look at themes and patterns that are emerging where they probably need to provide more guidance or lean into it more. And so I think on a lot of what we're seeing where managed care plans have kind of been given permission to do what they want to do with it, I think more and more the state is going to kind of pull that back and say, no, this is where we think everybody should be doing it the same way. So we may see more of that coming out.
I hope we do with closed loop referrals. So it's going to be a mess for
Yeah.
have some standardization.
Yeah.
Now, I take it that even though closed loop referrals will be a requirement, what I'm also curious about is we've gone through the services that are ECM and the services that are community support. Are the managed care plans allowed to choose which services they implement in ECM and in community supports? Or are they required to implement all of them?
So ECM is a Medi-Cal benefit. They're required to do ECM based on the state policy guide. So that is a standard that all managed care plans have to do. The community supports are not Medi-Cal benefits. So the managed care plans can offer all 14 community supports. They can just offer one. And as of yet, we have not seen a managed care plan pull back some of their community supports, but some have not offered all 14, and that could be a provider issue. It could be they're not able to do it. We have in California, we have commercial managed care plans, which serve multiple counties, and we have local managed care plans like Santa Clara Family Health Plan. that may only serve one county. And I think some of the smaller managed care plans have had a hard time ramping up as quickly as the commercial plans. Not always, but some have. Santa Clara Family Health Plan has done a great job, but I think there is variation in the plan's capacity and their investment in the community supports in particular.
And are there timeline expectations? In other words, a service can be offered, but it essentially becomes pointless if the wait period to be able to access the service is so great that it isn't going to meet the child's or the adult, whichever the case may be, their needs, right? So are there any timeline requirements for how quickly these services have to be accessible and delivered?
Great question. So the state does have timelines for the plans to authorize ECM for a certain individual or community supports. And they do have certain services that are expedited, which means I think it's a 72-hour turnaround time for those services. And I think the managed care plans have done a pretty good job following those guidelines. It's never as fast as providers want. And I think that's going to be a challenge that we're going to face. Now, some plans, and I will say Santa Clara Family Health Plan has done a great job with this. They're trying to figure out ways to reduce the paperwork to expedite the authorization for certain services. So I think there are plans that are trying to really make adjustments to streamline the services and really get folks into the services they need faster.
So I think it still is about the authorization being within 48 hours, but services to begin line for that after authorization. And I'm wondering if we can build that into our MOU for the child welfare population or IHSS or whatever population of focus our MOU is about. For me, it's child welfare.
So I know in most managed care plan contracts with ECM and community supports providers, there is a timeline that they lay out. Once you receive that referral, you have. So I think if you wanted to include a timeline in the MOUs, it might be good to make sure it's in alignment with what's in the managed care plan contracts with the providers. And again, I haven't seen all of the managed care plan contracts, but the ones I have seen do have a timeline built in for providers to respond to folks.
And I think also for the MOU, you know, kind of the technical ways that all of this work is going to happen, really looking at policies and procedures to capture a lot of that you don't want your MOU that's already, I think it's like a 4 or 5 page document that now, because you add all this detail in there, becomes this 20-page document, right? You'll notice that they don't really call out ECM, CST, CS services in the MOU. The thought is that you would capture more of how you're going to do it at the local county level through your own policies and procedures that you're going to work out with the managed care plans. What we learned in conversations with one managed care plan is that anytime you identify a policy and procedure in an MOU, for them, that's a compliance and potential auditing mechanism. And so they may want to avoid anything that would create additional work for them. But I agree, Jackie, there needs to be a really clear understanding of what the flow is going to look like with deadlines and timelines. And, you know, sometimes we can't wait even 72 hours for services to begin, right? We want them right away. And so the state is looking at presumptive authorization for certain providers for each of the populations of focus. And so that might help. You know, you can refer a member to a ECM or CS provider directly, and then they can seek the authorization from the managed care plan. Does that make it go any faster? I don't know, to be honest. You know,
from having managed contracts and MOUs for many years, what I find is if it isn't written down as a requirement, policy doesn't really impact what someone outside of our own organization does with that policy, right? So we can have policies and procedures within child welfare. It doesn't hold anyone outside of our department accountable to them. And certainly not anyone outside of the county's system, right? So part of what I'm hoping we can do is come to some agreements in the MOU, because ultimately, we want to make sure that whatever we can capture in the MOUs, I know that the state's template is broad and non-specific. From what I understand, there's no prohibition from being more specific in the county's MOU with the managed care provider or with the specific population of focus. So child welfare, for example, can have some requirements called out that may be requirements that the managed care plan already has in place with their providers, and maybe they would be willing to add that as part of the child welfare population so that we can get, some of the most vulnerable, right? We have a population of focus being foster care, but at the same time, we want to make sure that these services are also available to avoid foster care if we can, right? So I want to build in some timelines where we can create the same type of urgency to avoid foster care as opposed to respond to foster care. So, just thinking ahead, we're engaged in discussions with the health plans, and we were waiting for the CWDA template to be out, which of course it was, Alex and Sarah presented that. So now we're at a point where we can start having specific discussions. But I think the lesson that I've learned, not with managed care plans, because I'm new to working with managed care plans, but I've worked with a lot of providers in my life. And if it isn't written down, you can't count on the goodness of human beings to make it happen, because sometimes it takes more than the goodness of human beings to make things happen.
Well, yeah, and the folks that are going to actually do the referral, the care coordination, they're not actually in the conversations with the MOU negotiations. And so
Yeah,
it needs to be something that an MOU is, you always need more than just the MOU for the line staff folks to really understand how this impacts their day-to-day work with clients.
yeah,
And the state final version of the MOUs are broad because they are wanting that local flavor added to it of what is your population's needs in your
yeah,
community. So for example, we have January 1st of 2025, 3 counties are going to have all of their foster youth automatically enrolled into the managed care plan. And what we learned through that is, and what we are learning, is that for one of the counties, 60% of their foster youth are placed out of county.
yeah. And that becomes a problem. Yeah.
It becomes a
And
problem
we're
because
having
that
a
plan,
similar issue. Yeah.
right, that plan is only offered in that county, and most of their youth are placed out of county with other
Yeah.
managed care plans. So their MOU would need to address that because that is a local issue impacting their population. So if you hear the managed care plan saying things like, no, the state just wants us to sign the version they put out, that's not accurate.
Oh yeah. I've
They
already
want
said,
us
yeah.
to add language to it to really
Yeah.
lift up local needs. Now, they do not want us to delete anything that is a contractual agreement for the managed
Yeah.
care plans with the state. But whatever we want to add and enhance that collaboration and coordination, we should be
Yeah.
doing that. And they fully anticipate MOUs that are unique to each county.
Yeah. Yeah. And that's where we're going to try and make sure we're capturing everything that we can in our MOU, so that even though they may have an agreement with a provider about a service delivery perspective, we want to make sure that it's captured in our MOU for this target population, only because we can't enforce that piece of the MOU. We can only speak to whatever we contract for. So I think at some point, the state needs to be clear that the draft that they put out is a draft that incorporates only the statewide requirements, and local organizations are expected to add their own requirements, so that we're all saying the same thing. I'm saying that to the MCPs, but I want to make sure that they're hearing it from all different sources, right?
Yeah, we have lifted that up to DHCS's. They're going to be putting out another version of the MOU FAQ document, and we have lifted up in there to add language that encourages language to be added to the MOUs, and that we're not the only ones saying it, that we need the state to say that as well.
Those are all great points, Jackie. Thank you for raising them.
Yeah, sorry to take up all your time.
No, I think everyone on the call is probably in a similar boat. So I think it's really good to share kind of what you're thinking about and how you're approaching things. So I appreciate all the things that you've raised.
And I just want to add last thing, don't feel that you need to rush into signing the MOU, right? It's a process. It's a learning opportunity. The managed care plans really don't understand the programs that county departments oversee and provide. They don't understand the child welfare spectrum. It's not just kids in care. There's so much that we do before they come into care, and then there's so much that we do after reunification services, right, are terminated and with our NMD populations. They also don't really understand the IHSS program and the workload and the structure of that. And so the MOU is a vehicle to kind of really start those conversations so that you understand them and they understand you better, so that when you add the language to the MOU, there's a clear understanding of why it's being added and why it's going to help facilitate this process. So that's going to take time. They do have to report back to the state quarterly on the progress. And if the progress is we're meeting and we're still talking, that is progress.
Yeah.
Right? So.
Yeah, I think some of the managed care plans haven't even contacted me to set up their local MOU with us, but I think some may already have enough, right? Because we have 3 plans, and the majority of what we see in foster care is probably touching some of the plans. The part that I'm trying to understand is some of this community supports and ECM hopefully can avoid foster care, right? So I brought this up at the last meeting that we need to find a way to be able to track information and data in terms of success for ECM and community supports to avoid penetration of any system, right? Whether it's the child welfare system or the probation system, whatever that may be, to try and figure out a way to not have to bring a child into foster care, and how do we capture that population at the state level, because it can't be by Medi-Cal aid codes. The Medi-Cal aid codes don't apply to the prevention work that we're doing, right? And so what I'm hoping is that we can have some sort of data sharing agreement as part of this MOU, so that we can actually track the referrals that are made that are for prevention work. Does the closed referral system address all Medi-Cal aid codes, or is it particular to certain populations of focus?
My understanding is for all Medi-Cal aid codes, but don't quote me on that.
Okay.
But I think how you're thinking, Jackie, makes a lot of sense. And I think it's a really good thing to pursue to see how to get that, whether it's the closed loop referral system or through another application method with the managed care plans. But I think trying to figure out the data piece is really important for all of these efforts.
Yeah.
And those things, Jackie, would be captured in the MOU under, so there's a section for quarterly meetings and what you're going to talk about there. And then there's a section around quality improvement, right? What you want to see and what they want to see in alignment could be captured in that MOU around that.
Yeah, I think like anything else, right? The direction we had from CWDA was to build relationships. And I think relationships are the beginning, right? And we can be theoretically in agreement and still end up in very different places about implementation. And really the MOU is how do we get to meet somewhere in the middle where we can meet the needs of the child welfare population, whether it's on the prevention side or on the services side once foster care begins, right? So we keep working towards it.
Yeah, and we at CWDA and CFPIC, we will be hopefully in August, we're going to be hosting some managed care plan and county meet and greets virtually. We've already done this. Yeah, well, we've already done this with Partnership Health and the 24 counties that they're in. We're setting that up with Anthem and the 16 counties that they're in. And we're going to separate it with child welfare for one meet and greet and adults and IHSS for a second. We're also working with HealthNet and Kaiser to set up something similar. So those hopefully will be rolling out August, September.
Great stuff, Jackie. Thank you. I think with Anthem and Kaiser, you'll get some good meet and greets for Santa Clara. So that's good.
Yeah, I've already started meeting with Anthem and Family Health Plan. I still have to meet with Kaiser, but from our county's perspective, at least the foster kids, we don't have that many in Kaiser. And you know, I'm still trying to figure out how to get that data as to what's the population of foster kids and the data about who's enrolled in each managed care plan. And it's becoming difficult to get that information. If you have any guidance about how to be able to get that, that would be helpful. Our eligibility staff is saying they have the ability to be able to see the data when they go into meds about what a child is enrolled in, but they don't have the ability to pull any reports about which plans children and families are enrolled in. And I'm wondering if there is a statewide way to be able to get that data for our county's children.
So I know the health plans are able to pull that data based on
Yeah.
just pulling it from the aid codes. There are many dashboards out there now tracking this that the state has. I'll be honest, I don't find them easy to navigate. And
Yeah.
so I had tried to look at, well, how many do we have in a managed care plan versus fee for service? Yeah, I don't know. Gretchen, have you tried
I
to
don't
pull that?
think, I don't think there's a magic system out there, but I think asking the managed care plans is a starting point.
Yeah, the managed care plan is, at least Family Health Plan said that they will try to see what they can find in their system. The challenge is when you get it from the managed care plan, they don't know if they can share the data with us. And I'm telling them, if it's a child welfare aid code, you should be able to share the data with us. It's but you know, we'll see where we get with that, because being able to do a cross-reference on the data to see if it's accurate would be really helpful, right? For us to understand the population a little bit better. But you know, the other question I had was, the state is sending out notices to caregivers, meaning resource parents, foster parents, relative caregivers across the board. When a child comes into foster care, a notice is being sent to the foster parent, for using it as a generic term, to select a managed care plan. And this is for children who were already enrolled, I believe, in Medi-Cal prior to coming into foster care. We used to be able to unenroll that child from a managed care plan, enroll them into fee for service, until they were stabilized, at least, because the first few weeks, especially, they're moving around, and foster child may not end up staying even in the county where they're first placed when they come into foster care. So these notices are going out to resource parents, foster parents, and then the child is defaulting to a managed care plan instead of fee for service. Does anyone know anything, or any of you hosting the webinar or anyone in the meeting, about how that's affecting other counties related to the child welfare population? No? Okay.
Does anyone else on the call have any information in their counties?
Yeah, so I can share that this is an issue that has come up for Kern County and CWDA, myself and Locke. We are assisting the county to kind of look out, and their issue is everyone that comes into care automatically gets defaulted to fee for service, even if they were in a Medi-Cal managed care plan prior to coming into care, and then they don't know how to now change them over to a managed care plan. And so we're working with their eligibility side first to kind of get a roadmap of how does this work, so that then we can go to the right people to kind of help them figure out, well, how do you then enroll them back into the managed care plan, make sure they don't get disenrolled if they were in a managed care plan
Yeah.
before. We're trying to work through that process, because that, like we've mentioned time and time again, all of these services are only beneficial to folks in a managed care plan.
In a managed care plan. So
Yeah.
maybe, Baljeet, I can chat with you after this at some point, if you have time later today or another day, about what's happening in our county and how do we go about figuring out what led to it so that we can address it.
Yeah, I'll
that
send you
would
an
be-
email. I'll send you
Okay.
an email. Yeah.
Thank you.
Uh-huh.
All right, great questions. I do want to spend the last little bit of our session today going over CalAIM funding opportunities. I know we touched on this earlier, thanks to Gloria's great question, but I do just want to cover it again with it on the screen so we can all just understand what's out there and how to access it. So there's a couple of different funding programs that support ECM and community supports. PATH funding has many different components. We're going to cover each of them because they're all really important, I think, for a county, no matter what role you choose to play in the Medi-Cal transformation. And then the IPP program funding that we talked about earlier, which is through the managed care plans. So what happens is the state gave the managed care plans some incentive dollars. Most managed care plans have chosen to give those out to providers as grants. Those dollars are coming to an end for most managed care plans. Some gave out everything early on and have zero left to give. Some have held on to their IPP funds and are rolling them out consistently. So it varies by managed care plan, but these are going away. And the intent for both the PATH funding and the IPP funding is to really help build capacity for organizations to do ECM and CS, and to make those investments for organizations to buy the care management systems they need, the billing systems they need, all of that good stuff. So I do want to just kind of highlight these funding streams, and I want to talk about the PATH components in great detail and encourage you all to take advantage of PATH. So PATH has been a catalyst for scaling ECM and community supports. I actually was just in a meeting with a bunch of providers saying that these funding streams, opportunities have been incredibly important for them to become providers, to be successful at being ECM and community supports providers. So they are very valuable. Some components of PATH will be drying up later this year. So I do want to highlight what those are, and if you want to take advantage of them, how to do so. So PATH has 4 major initiatives that the state has funded. The first one we touched on briefly is this Collaborative Planning and Implementation Initiative, a CPI is what it's called. And these are collaboratives that are happening in every county. Some counties are pulled together if they have similar health plans. And the state has paid for facilitators to run these collaboratives. There's monthly meetings. Most facilitators have quarterly in-person meetings, which I think are the most important if you wanted to attend one. Those are the ones to go to. You get a chance to meet other folks involved in ECM and community supports, get to hear about where the health plans are in your county, what they're thinking about with IPP, with other initiatives, and really do some good networking. The counties are really desired to be part of these conversations, to be at this table, not only as providers, but also to offer insight into what's needed in the counties, what gaps exist, what's working well from their perspective. So I really encourage you all to sign up. And I know Baljeet had put in the chat earlier the link to sign up. You do have to sign up through the state's website, and then you will get an invitation from your county collaborative to join their meetings. But these are very valuable. So I encourage you all to check it out. So that's one part of PATH. The next one is going to be our PATH Cited, and this is the funding stream from the state. These are grants the state gives out directly to providers who are wanting to become ECM or community supports providers, or who already are. This is going away. There's one more round of funding left of PATH Cited. We expect that to open October 1st. The state usually opens the application window for 30 days. And so you don't have a lot of time to take advantage of this. If you as a county are thinking about becoming an ECM or community supports provider, or you have community partners who you would like to see become a provider, these funds are critical. So I encourage you all to check out the website. If you do want to become a provider, think about what you would want to get funding for. Again, you can use this to hire staff, to buy care management systems, billing systems, buy computers. There's a whole range of things that the state funds. And again, trying to build capacity for those ECM and community supports providers. So this is going away soon. So I want to make sure folks are aware of what's out there. And if you do want to become an ECM or community supports provider, or if you already are one but need more funds to help build your program, Path Cited is a great opportunity. The next initiative under PATH is what's called the TA Marketplace. This is a place where providers can go to get free technical assistance on ECM and community supports. The state pays for these vendors to provide you with assistance. I have to say it's a little overwhelming because there are a lot of vendors on there, and we're hoping that CFPIC can become a vendor later this year to offer more TA to all of you. But there's a lot of vendors out there with a lot of expertise in different areas. There's, I think, 6 different domains they can offer TA in: data capacity, ECM, community supports, workforce. So there's a lot of opportunities here. The process is a bit, how should we say it, slow to get this up and running. You have to apply to be a TA recipient, and then you have to choose a vendor to work with, and that can take sometimes 2 months to get this up and running, but it is a really great opportunity, and you can work with different vendors on different projects. So if you need help with a data system, you can work with a TA vendor on data. If you want to work on getting training for ECM, you can choose a different vendor for that. So really great opportunity. Check this out. At this point in time, we don't have an end date for the TA Marketplace, so I expect this to run the full 5 years of the waiver, which means there's 3 years left. So take advantage of that. And the last piece under PATH is really focusing on the justice involved. Oh, let me go skip this here. Justice involved capacity building. This is really trying to help support the JI population of focus, both with the post-release services that have gone live through ECM, as well as with the pre-release services, which will be starting October 1st. Each county can choose when they opt into that. But these are, again, capacity building dollars. Most have been targeted towards counties, probation, sheriff, other county agencies. So check this out. I think there's a couple more funding rounds under the JI initiative for PATH. Questions on PATH? All right, well, now I'm going to leave you with a whole bunch of resources for both ECM, community supports, and transitional care services. These are all linked in the PowerPoint. They're all on the DHCS homepage as well. But I really encourage you all, if you're thinking about becoming a provider, or if you know other organizations who should be a provider, there's a lot of great information on all of these links and resources. You can also share this PowerPoint with your colleagues. And again, if you do want to jump into being a provider, we do have these startup dollars, the IPP through the managed care plans, Path Cited through the state, that will be going away. So please look at those. And if you decide to hop in, try to apply for additional funding to help fill some of the gaps you may have with, again, infrastructure, staff, other components of your program. So session wrap up. Thank you all for being here today. It's been really fun to hear your questions, to share some information with you. I do think counties have a really important role to play in ECM and community supports, and figuring out which role best fits your county is going to be important. But I really encourage you all to think about how to help folks access these programs that can benefit them, take advantage of the funding that's out there to support some of these services. So I, again, hope it will inspire some thoughts and some folks to maybe offer a training on CalAIM, or to encourage your partners to really make more referrals into ECM or community supports. I'm going to do one more plug, Andrea. I know you're thinking the same thing about our TA. We do have one more office hour coming up Friday afternoon. If you have questions, want to talk more, please hop on 5 minutes, a half hour, whatever you want at any point during the 3 hours. We welcome you to join us and ask your questions, and we can review slides, we can share other resources. So it's a great opportunity for another conversation with Baljeet, Andrea, and myself. And Andrea, do you want to say a last few words?
I mean, you took the words right out of my mouth, but I do want to thank all of you for asking questions and interacting with this material, because I think that the question process and the thoughtful responses really enriching the training. And so I just wanted to say thank you. I mean, you're sparking ideas for all of us to learn, and we do hope to be able to nurture ongoing forums for learning and sharing to strengthen everybody's CalAIM implementation. So thank you so much for coming and for participating. Yeah, we'll see you June 21st. I dropped the flyer into the chat earlier. Just register. The only reason that you need to register is because that prompts the Zoom link to then be sent to you. So hope that you will bring further questions. Bring your partners. If any of you want to bring your CBOs or your colleagues that are also working on contracts with you, or your partners in the MOU development process in your county, bring them as well. It doesn't mean it's just you, but bring your partners as well to the TA session on the 21st. And thank you so much, Gretchen, Baljeet. Thank you to all of you. It's been a great morning, and I will follow up with the recording that will be out to you within the week. All right. So with that said, I will just formally dismiss us unless there are other questions.
Thank you all.